Okay, I think we'll get started. This session is on interventions for LV reconstruction and support. I think we're going to hear a lot of novel concepts. And to start us off, we'll have Dr. Patrick Klein to talk about concepts and update on results.
Okay, thank you. So here are my disclosures. So post-infarction left ventricular remodeling leads to changes in LV shape and function, as we all know, and the normal elliptical left ventricle tends to sphericity and chamber dilatation, while transmurality and extent of the myocardial scar determines whether or not a true LV aneurysm or dyskinetic segment develops. So despite all the advancements made in recent years in the pharmacotherapy of heart failure and all the improvements in mortality and morbidity, the prognosis of mainly ischemic heart failure is still grim. You see here two important papers on pharmacotherapy on beta blockers in heart failure. Left is the Pecker paper, New England 2001, showing that the effect of adding carvedilol to treatment, but mortality is still like 18% in 18 months. And to the right, the Groot paper in American Heart Journal, showing that patients put on beta blockers, if they didn't improve their ejection fraction, when their baseline was below 45%, with at least 10%, their prognosis is pretty dismal. From the surgical history, we know that conventional or surgical left ventricular reconstruction in selected cases, there is a lot of observational data showing potential benefit. What it does, it surgically reduces the LV volume and reconstructs the elliptical shape, which leads to reduction in wall stress, improvement in systolic function, improved twist and torsion, but the expense of reduced diastolic function. Here to the right are some pictures showing the surgical procedure. It was done by median sternotomy using extracorporeal circulation, cardioplegic arrest, and ventriculotomy, so quite an invasive procedure. Using a patch to after volume measurements to close any deficits. So, and then came the STITCH trial, as we all know, by Jones, published in New England 2009, showing basically no benefit of adding surgical ventricular reconstruction to coronary surgery when patients were eligible for both. There was no difference in mortality, none in morbidity, readmissions for heart failure, or improvement in symptoms or exercise capacity. And then a large debate in the surgical community arose to what are the viability of this study, and there came insights and sub-analysis. And one important thing, analysis by Michler, showing that there is indeed a big difference in mortality when the ventricles are reduced below a volume, end-systolic volume index of 60 milliliters per square meter of body surface area. And then when you look back into the original STITCH data, there's actually an average reduction of only 13% after SVR plus CABG, and 70% of the patients didn't demonstrate not any increase in, no decrease or even an increase in end-systolic volume index. So our study objective here is to describe the concept of a novel hybrid transcatheter technique to reconstruct the remodeled left ventricle by plication and exclusion of the scar, a reduction of the excess volume, resulting in decreased wall stress and increased ejection fraction, to provide an update on our preliminary results. So here's the concept. We reconstruct the left ventricle by putting the anterolateral scar in contact with the septal scar and exclude the intervening segment. We did that without sternotomy, no extracorporeal circulation, no cardioplegic arrest, no ventriculotomy, or the use of an akinetic patch, and just by micro-anchoring technology over peak theta. So here's a short animation describing the procedure. So the scar, transmural scar, is depicted here in purple. So start off with a 14 French introducer going into the internal jugular vein, deploying a Swan-Ganz catheter, floating it into the PA, through which goes an 025 guide wire, advancing the introducing sheet, then taking the Swan-Ganz out, and an 8 French multi-purpose catheter is then advanced, through which a snare is deployed in the RVOT. We can actually also do this in the apex of the RV, depending a bit also on morphology. Then we puncture the scar from the lateral one through the septum with a 18 gauge strong needle, over which goes a 032 guide wire, 6 French introducer, and then a 5 French right-angled guiding catheter. It's pulled against the septum, and then we guide a 018 guide wire into the PA, snaring it down, and then pulling it all together. So when you advance all this and then introducing catheter in, we have a protected rail through the heart, through the septal scar and through the lateral scar, in which we can deploy internal anchor assembly into the septum. We swivel that, and then a pairing external anchor goes against that over the tether and pushes the lateral scar against the septal scar. Then we check with TUE if there's no valvular incompetence, and then we release this first anchor pair. And then we use multiple of these anchor pairs to reconstruct the LV, usually around 3. So small incision, combination of minimal invasive surgery and transcatheter techniques. So here are our patients who are considered eligible when they have symptomatic heart failure, NYHA class 2 at least, ischemic cardiomyopathy, EF below 40%, after an anterior myocardial infarction. They all had a dilated left ventricle, either A or disconnected scar in the interseptal wall and an apex of at least 50% transmurality. And we use late enhancement MRI to determine scar size and extent. And if patients had an ICD or other device which prohibited an MRI, we used cardiac CT. 4D. So here's an example of a procedure. So we start off with this is the patient on an LV angiogram, huge apical aneurysm, preserved basal motion, symptomatic patient, NYHA class 2. This is the RV angiogram, pigtail catheter into the apex of the RV. So here's the septal puncture. I've stained the myocardium here a bit because we use multiple ways to check when we have passed the septum and are into the RV. So we use contrast and we use pressure readings. So in the middle we've snared the wire, and here we've completed the rail. We still have to advance the introducing sheet. So here the first internal anchor pairs deployed. Here's actually some pushed along a bit away, a bit of gauze. So here the first internal anchor pair is swiveled against the septum, and then the pairing external anchor pair is mounted on it. This is the first pair plicating, first part of the left ventricle. So in here you see the completion. We have deployed 3 anchor pairs, and this is the new ventricular shape and function. And then if you recall, this was the preoperative situation. So, to give you an update on our results, so we've done 16 patients so far in our single center. Here, demographics to the right, NYHA class 3 on average. So we use 2.6 total anchor pairs, usually 1 internal, 2 external. Procedure takes about 2 hours, 45 minutes. So we had 1 lesion of tricuspid valve, necessitated repair, or actually replacement of the tricuspid valve with a biprosthesis, 1 positive revision because of RV restriction, a little bit too much bulging of the RV because of glycation. Average duration of ICU stay is 1 day, and medium length of hospital stay is 6 days. It's the echo data showing pre-op echo ejection fraction 33% going up to 43, increase of 36%. So the volumes go down, average with 43 and 33%, other end-systolic or end-diastolic volumes. We have so far no mortality, no strokes, no readmission for heart failure, with 1 readmission for PCI of the RCA and 1 after ICD therapy. So this is demonstrating in bars. This is on the indexed volumes going down from 58 to 32, 83 to 54. So here you see the symptomatic status over time. So here we started out with our 16 patients. Here's the change directly post-operative in ejection fraction, and then this is at latest follow-up. It's now, on average, little over a year. 2 patients are in NYHA class 3, and 11 patients are NYHA class 2, and 3 are in NYHA class 1. So, of course, very selective patients, I have to admit, obviously. In conclusion, hybrid transcatheter LV reconstruction is a promising novel treatment option for patients with symptomatic heart failure and ischemic cardiomyopathy after anterior myocardial infarction. And these early results demonstrated the procedure is safe and results in significant improvement in ejection fraction, reduction in volumes, and symptomatic status of the patients.
Great. That's really a nice start to the session. Are there you have a comment? Any comments, questions? Yes? Yes.
Well, can I take it first? I was thinking this is a fascinating procedure, and I was thinking this I want to do, and I was thinking, well, we could do it for the door patients that we treated before, but then we're looking for patients, and I cannot see any patients anymore because we treat them too good with the revascularization. So how do you find the patients?
Well, there are multiple options. So some of the patients we followed up from the cath lab. So they came in with a huge anterior infarction, got a primary PCI, and then we just put them on follow-up. First optimized them, treated their heart failure. If they stayed symptomatic, then we considered them eligible for this procedure after device therapy. Some came from a screening through our MRI database and then looking up, asking their heart failure cardiologist what happened to these patients. So there are multiple ways, and some come from the EP lab. Patients come in after, I think 4 of these patients actually had device therapy, ICD shocks, were still symptomatic, were all optimized, and from the EP were sent to us for to consider treatment.
Yeah, I think if you treat quite a lot of ICD patients, if you have them under your control, then you will find these patients easily.
If I can add a comment, we had the same issue, but indeed there is plenty of those patients who run away in heart failure clinics, general cardiology and internal medicine, and they're never referred just because the door procedure is felt to be too risky.
Exactly.
So they actually denied therapy. One is one key thing. The other thing is, did you address functional mitral regurgitation in your patient, and how did it behave after volume reconstruction?
Yeah, that's a very interesting question. There's one patient with a severe functional MR, and it decreased to mild after the procedure. I just saw the patient last week on the outpatient clinic. He's now, I think, 7 months after procedure, and it decreased. So there's, of course, the reduction in volumes reduces the tethering on the mitral leaflet. So I think this is very interesting technique to functionally address the FMR by reconstructing the ventricle, reducing functional MR. But so these are only 16 patients. So 1 had severe functional MR. There were 2 or 3 who had mild functional MR. So I don't have a lot of data to support this. But the one patient who had it did show a decrease in functional MR.
Thank you. Oh, one more question. Last question.
One question. Do you require patients to use blood thinners post-procedure just because of the potential risk of ventricular thrombi? Looking at the procedure, it looks like you might have some pockets that you create.
Yes, yes. So if there's an internal external ankle pair, so there's actually uncovered anchor in the RV on the septal side, we give them coumadines for 6 months. Most of these patients were already on coumadines because I think at least 30-40% had thrombi in the aneurysm before we started. So we first put it on, made sure the thrombus was gone, then we operated them. If there's only external anchors and the aneurysm is completely, and the ventricle is completely reconstructed, no dyskinetic areas left, then we don't give them coumadines. But normally with internal ankle pairs, we give them 6 months of coumadines.
Okay, thank you very much.